My name is Priya Jayachandran. Thank you for the very generous introduction. I'm a breast medical oncologist. I'm the co-director for the breast program at El Camino Hospital in Mountain View. I'm also the medical director for research. And I'm going to jump in where Dr. Liu left off, my wonderful colleague, as we explore some of the updates in early stage breast cancer. So I'm going to start out by just stating the obvious. Why does any of this matter? Because your health matters and you matter. So I hope that one of the big themes that you take away from today is that cancer treatments are improving, outcomes are improving, and people are living longer. And it's important to keep in mind that there's a lot of risk factors that can play a role in someone developing cancer. Unfortunately, a lot of those are not in our control. Things like our genetics or our family history are not things that we can change. But there are modifiable risk factors. Things like the diet that we eat, the type of physical activity or exercise that we do, those are things that we can change and that can reduce your risk of getting a breast cancer, or if you've already been diagnosed with a breast cancer, can decrease your chance of a recurrence. Now, what are the symptoms of an early breast cancer? Well, you might feel a lump, you might notice some changes in your skin or in your nipple, but the fact of the matter is, particularly when we're talking about a very early stage breast cancer, there may be no symptoms at all. And that's why it's so important that we screen with mammograms. Here we have a depiction of the anatomy of the breast. Our breasts are largely composed of fat as well as glands. 2/3 of breast cancers will arise in the cells of the milk ducts. We call those an invasive ductal cancer. About 1/3 will arise in the lobules, and we would refer to those as an invasive lobular cancer. I don't need to say it here, breast cancer is exceedingly common. About 1 in 8 women in the United States will be affected by breast cancer at some point in their life. And important that we acknowledge that although it's rare in men, it does happen at a ratio of about 100 to 1. I currently have several gentlemen who I see in my clinic for their breast cancer diagnoses. And as I mentioned, early stage breast cancer is often asymptomatic. It sneaks up on people, and that's why we screen with mammograms. Statistics show that for every 1,000 women who undergo a screening mammogram, when all is said and done, about 5 will be diagnosed with a breast cancer. So thankfully, that doesn't seem like a very high percentage, but for those 5 women, that could truly be a lifesaver. Now, the nuances of who to screen, how often to screen, and when to screen are a little bit complicated. They have changed over the years in terms of the recommendations. For those at average risk, the United States Preventive Services Task Force recommends that we start screening at age 40, and they recommend every other year mammograms. The American Cancer Society, on the other hand, has slightly different recommendations. They also suggest that we consider starting at age 40. They consider a standard recommendation to do annual mammograms from the ages of 40 to 54. And then they give the option to kind of ease up and do every other year from the ages of 55 onwards. But what everyone agrees upon is that certain people are at higher risk of breast cancer and should be offered more intensive screening. So things that could place someone at higher risk for breast cancer might be having a BRCA mutation. It might be having very significant family history. Maybe somebody was diagnosed with Hodgkin's lymphoma as a teenager and they received radiation to the chest. All those things could put someone at a higher risk for developing breast cancer. And in those cases, we may start with screening as young as age 25, and we may supplement our annual mammograms with MRIs. So somebody may actually be undergoing imaging every 6 months, mammogram, then MRI, then mammogram again, so that we can really try to catch something early should it arise. I'm not going to spend a lot of time talking about staging. It's important to acknowledge that there is an entity called DCIS, or ductal carcinoma in situ. We sometimes think of that as a stage 0 breast cancer. We differentiate stage 1 to 3 breast cancers based on the size of the tumor in the breast and the extent of involvement of the lymph nodes under the armpit. And then we refer to it as a stage 4 breast cancer when the cancer cells have spread beyond the breast and the lymph nodes under the armpit to other parts of the body. Breast cancer has a tendency to go to the bones, the lung, the liver, the brain. Essentially, it can go to any part of the body. Today we're talking with a primary focus on early stage breast cancer. So we take into account the stage at the diagnosis, but we also take into account the subtype of a breast cancer in determining what's the best possible treatment. When we're referring to the subtype of the cancer, we're most commonly referring to the presence or absence of 3 different markers. Markers are basically little proteins that sit on the surface of the cancer cells. One of those is the estrogen receptor. We abbreviate that ER. Another is the progesterone receptor. We call that PR. And the third is a protein called HER2. So based on the stage, based on the subtype, we develop a treatment plan. Often that's a combination of surgery. We may also include radiation. We may also include chemo. And in some cases, we may also include endocrine therapy if the estrogen receptor is positive. I've said it before, and I'll say it again, outcomes are improving. Now, breast cancer is not a new diagnosis. We've known about it for a long time. Actually, some archaeologists have found references to breast cancer in ancient Egyptian scrolls. And they found these relief carvings and paintings depicting very rudimentary surgeries for breast tumors. But it's really in the last 100 years or so that we've developed our modern conception of treatment of breast cancer. In the 1930s, we first started using radiation. It wasn't until the 1970s that we started using our first modern chemotherapy drugs and hormonal agents like tamoxifen, which we still use very commonly today. In the 90s, we had our first biologic drugs, things like Herceptin or trastuzumab, which is a monoclonal antibody targeting HER2. And in the last 25 years, we've really started using genomic profiling of cancers. So going beyond the cellular level down to the genetic level to really try to understand the behavior of a particular cancer. And we also have a lot more targeted therapies where we can exploit certain mutations that we may find in a tumor. This is Dr. William Stewart Halstead, credited with performing the first radical mastectomy at Johns Hopkins. As Dr. Liu described, we thankfully now have skills to perform much less morbid and much less disfiguring surgeries. This picture never ceases to amuse and terrify me. We have this poor woman who's about to undergo a procedure on her breast, and she has these 6 men hovering over her in their suits. No one's wearing gloves. The gentleman in the front looks like he has a screwdriver in his hand. I'm not sure what that is. And she's putting herself there to get treated. This is Dr. Cerny. He was a German surgeon credited with performing the first vaginal hysterectomy. He's also sometimes referred to as the father of plastic surgery. He removed a tumor from someone's breast and then relocated a lipoma from another part of her body to repair the contour defect. And this is Dr. Stephen Paget, after whom we've named Paget's disease of the breast. But of course, if you're diagnosed with breast cancer today, your OR is not likely to look like that, nor are your physicians, and your team is much more likely to look like this. This is our multidisciplinary crew at El Camino. And we're very proud to work together and provide the most comprehensive and compassionate care to our patients. This is Dr. Tran Ho. She's my co-director of the breast program at El Camino. And we also have a large team of very dedicated nurses and medical assistants who all strive to provide the best possible care. In the middle is Dr. Bob Sinha. He's one of our core radiation oncologists. He is a man, but we allowed him to join our picture here. So the history of modern chemotherapy did not really have very glamorous origins. Actually, they used mustard gas during World War I in 1917, and they just kind of found that it was destroying these soldiers' immune systems. Their white blood cells were just getting wiped out. And so in the 40s, some doctors at Yale decided to repurpose that chemical, and they tried it on a very terminal patient. Rules were much more lax in those days about doing experiments on people, and this patient had some degree of response. Now, the records from that patient are lost, and so some of the details about this case are kind of folklore at this point. Here in a picture, we have Dr. Paul Ehrlich, sometimes referred to as the father of chemotherapy. He wrote about this concept of trying to pioneer a magic bullet, something really targeted to treat a disease. And he actually wasn't looking at cancer. He was trying to find a cure for syphilis. But nowadays, when we say chemotherapy, we all assume we're talking about cancer, but really the word is chemical treatment is what chemotherapy means. So you could think of your heart medication or an antibiotic, really it all is technically chemotherapy. But this idea of a magic bullet is still something that inspires oncologists today. And this is a picture of a lab from the 1950s where they were doing some experiments to try to develop some chemotherapy drugs. But jumping forward to our modern era, there's so many advances that are being made on a daily basis. And I think it helps to kind of focus on 4 major themes. The first theme that we're going to talk about is the de-escalation of chemotherapy. So I kind of walked you through, over the years, we've developed all these chemo drugs. But now we'd really like to see, is there something we can do to spare people some of the side effects? Because chemo really kills, poisons, the most rapidly dividing cells in the body. And because of that, there's a lot of side effects that can be associated. These are just 2 examples. There are literally hundreds of trials going on looking at the de-escalation of chemotherapy. One of them is the APT trial. This is for early stage HER2-positive breast cancer. We traditionally use 2 chemo drugs and 2 HER2-targeting monoclonal antibodies. This is looking for very small tumors using 1 chemo drug and 1 monoclonal antibody, and the outcomes seem to be very favorable. The other is a very landmark study. It's called the TAILOR-X study, and this is utilizing genomic profiling. So this is looking at women with ER-positive and HER2-negative breast cancers and running a test called the Oncotype test, which is now very much part of our standard of care, to see who we can safely omit chemotherapy for. In those cases where we omit chemo, we're generally relying even more heavily on endocrine therapy. So these could be pills like aromatase inhibitors, that could be anastrozole or letrozole, that block the conversion of testosterone into estrogen. Or it might be a medication like tamoxifen, which binds and blocks estrogen from having its effects on its receptors. These pills can be given for anywhere from 5 to 10 years. As an aside, tamoxifen is not chemo, but we're trying to de-escalate in a lot of areas. And for DCIS, we now have 10-year follow-up data on a trial referred to as the BABY-TAM trial. So that was looking at giving a dose of 5 milligrams of tamoxifen over 3 years in lieu of 20 milligrams over 5 years. And for DCIS, the outcomes are very good. So very important that we continue to do the research, continue to do the studies, because there's so much to be discovered. We've obviously come a very, very long way since the first radiation treatments were done, and our equipment is so much better now. Here's a newspaper ad from 1912, someone promising to give $1,000 if they fail to cure any cancer. They say they had some kind of potion that was made from some sort of tropical plant, and any lump in a woman's breast is cancer, and if neglected, it will always poison the deep glands in the armpit and kill quickly. Thankfully, we know that's not actually the case. But unfortunately, I think throughout history, when there's a problem, there's unfortunately people who will try to take advantage of the despair that people are going through. And I think that has always been the case. But that's why research is so important. And we're never trying to take away someone's hope. Research and trials are how we keep this hope going. And it's so important in terms of someone's response to treatment and their survival that they hang on to hope always. There's actually some really interesting studies going on the concept of hope. And some people say that it's actually a cognitive skill. It's something that we can learn and develop and utilize. And they've actually shown that 2 people in a very similar situation with very similar cancers getting very similar treatments, somebody who has hope actually tolerates the treatment better and responds better in the long run. So some people are looking into what can doctors do differently and what can patients do differently to really utilize hope as a therapeutic target. All right, I know we got a little bit of a late start, so I'm going to move a little bit quickly here, and I might skip through a couple sections just in the interest of time. But I did mention the Oncotype test. This is one of our genomic profiling studies that we utilize regularly. This test looks at the expression of 21 genes in cancer cells and comes up with a risk score. So a very high number on that indicates that it's a more aggressive cancer, more likely to respond to chemotherapy, whereas with a lower score, we may be able to safely omit the chemo and just utilize the endocrine therapy. MammaPrint is another genomic profiling test that we use. This categorizes tumors from ultra low risk to high risk 1 or high risk 2 categories. We can also use this information to make decisions about chemo. And there's a third test called a breast cancer index test that we sometimes use to help determine the duration of time that someone should be on endocrine therapy. The last two categories go together nicely. So traditional chemo, as I said, unfortunately has a lot of side effects. So it kills a lot of our healthy cells along with the tumor cells. Immunotherapy really tries to be more selective. It tries to target the cancer cells and basically push someone's own immune system to fight them off. So oftentimes when we use the word immunotherapy, we're talking about checkpoint inhibitors. Those are medications like Keytruda or pembrolizumab that we are now using a lot in triple-negative breast cancer. But there's also drugs like Herceptin, trastuzumab, which are monoclonal antibodies, and those can also be considered immunotherapy because, just like you get a vaccine to help you fight off an infection, in the same way, these are antibodies that are targeting the specific marker on the cancer cell. And the other two categories mentioned here, tumor vaccines and CAR T-cell, are still very much in active research at this point. Won't go into this in too much detail, but drugs like Keytruda basically take off the brakes that cancer cells can put on the immune system. So it basically activates the immune system, the T cells, which are a type of white blood cell that we all have, and allows them to more actively and aggressively target the cancer cells. And antibody drug conjugates are an even newer category of medications that we use. And this is kind of combining two different classes of medications. So we're using an antibody like Herceptin, but linking that molecule to a chemo molecule. So it actually delivers the chemo directly to the cells that express that particular marker. And so the idea is that it'll be more effective, more targeted, but also have less side effects. Of the three examples here, Kadcyla is one that we use in the early stage setting. The other two are in the metastatic setting. So as I said, breast cancer incidence increases with age. There are some risk factors that we can change and modify, and some we can't. But outcomes, thankfully, are improving. In the interest of time, I'll briefly mention liquid biopsies. These are blood tests that we can use to actually isolate cancer cells from the blood. So we can do tests on those cells and get a lot of the same information that previously we actually had to put a needle in and take a biopsy from a tumor. And we're now using this for surveillance, so we can actually measure the amount of cancer cells in the blood. And if that level is increasing, that could indicate to us that there is a recurrence or relapse of the cancer. Dense breasts, when we use that term, we're just talking about the relative amount of glands and connective tissue relative to fat in the breast. And as you can imagine, our radiologists are very good at identifying little specks of white or little splotches of white that are suspicious for cancer. But they would have a much easier time identifying a potential cancer in the midst of panel A, which is a fatty breast, versus panel D, which is an extremely dense breast. So when someone has dense breasts, we oftentimes recommend an MRI in addition to mammogram screening. Skip through this. Survivorship is so important. Thankfully, people are living longer and longer and healthier lives after their cancer diagnosis, so it's very important that we support them through all the aspects that come into play. And I will go through this fast. We've covered a lot of information here, but we'll run through this as a team because teamwork always makes the dream work. Here's our crew from El Camino. Question 1, true or false? If you don't have family members affected by breast cancer, screening is optional. I'm seeing a lot of people, yes, all right. Only 15% of women diagnosed with breast cancer have a close family member. So 85% of women, it's kind of out of the blue. It's unexpected. Question 2, true or false? The 2 most common risk factors for breast cancer are being born a woman and getting older. Okay, so it is true. So we talked about some modifiable risk factors, we talked about genetics, but important to know your family history. At what age should women at average risk start getting their mammograms? I love it. Everybody's been listening and paying attention and knows what to do about breast cancer here. All right, true or false? Is there anything that we can do to affect our risk? Yes, so things like exercise, diet, limiting or avoiding alcohol are all helpful things that we can do. And which of the following is not a theme in the current treatment of early breast cancer? De-escalation of chemo, increasing use of immunotherapy and targeted therapies, more personalized treatments, less long-term surveillance, or improving outcomes? Perfect. So people are living longer, so we actually need to do more long-term surveillance. And we're now doing things like liquid biopsies, looking for circulating tumor cells. And so we have new ways of following people and trying to identify a relapse early. But long-term surveillance is essential. So I will finish there. I know I went over time a little bit. I apologize for that. But for those of you who've never been diagnosed with breast cancer, please talk to your doctor. Make sure you're doing your mammograms. If you're currently going through a cancer treatment, stay in close touch with your doctor so they can support you through this time and get you through your treatments. And if you're a survivor, congratulations, that's something to celebrate. But again, stay in touch with your doctor because there's things that they can do to help you for the rest of your life.
Questions? We have microphones.
How accessible is that blood test, liquid biopsy? Is that something I can ask my doctor for?
Yeah, so good question. So there are a number of companies that provide this type of testing. It is not standard of care for early stage breast cancer. So by the guidelines, it's not a routine thing that everybody should be undergoing. But you can certainly speak to your physician about whether that would be appropriate for you as part of your surveillance program. There's no standard or set interval to be doing it either because it's not yet the standard of care. So it's very much on a personal case-by-case basis at this point. I suspect that down the road it will become more of a standard part of our surveillance plan. But at this stage, yeah, you can talk to your physician and discuss what's right for you.
Yes.
Oh,
I have a sentinel node that doesn't show up on mammogram. Oh, and a sentinel node involved a cancer that didn't show up on mammogram. Would an ultrasound of that area be part of surveillance or not?
Could you clarify a little bit? You were saying that you had a sentinel lymph node biopsy and it was positive for cancer?
Yeah, and I had it
And
removed.
did not show up on...
And when they tried to take an ultrasound to, show the tag, they wound up taking like 7, and they couldn't get the tag. And finally I said, is anyone counting these?
I see.
And they went, oh, you're right. And I said, I'm sure. But anyway, a year later, the doctor was saying, a mammogram's sufficient. And I'm saying, but that won't look at that area. Don't you have to check that area this year later?
Yeah, so it is controversial if routine ultrasound of the axilla is part of surveillance. And right now, it is not the recommendation.
Okay.
But if we do a mammogram and we do the diagnostic ultrasound afterwards, usually your breast radiologist will be catching the armpit in the side views. And when they do the ultrasound, they normally do scan in the armpit. It's just not part of guidelines. So we are looking, and if we see something abnormal, we may investigate. But
they wouldn't see it if they don't do the ultrasound.
No, you could catch lymph nodes on mammogram.
Huh?
You can see lymph nodes on mammogram.
No, I know you can't see those lymph nodes because they tried to check the tag and they couldn't see the tag on ultrasound, and they took like I said, half a dozen or more ultrasounds trying to catch the tag, and where it was, they couldn't see it.
Your lymph node was tagged before surgery?
Yeah.
I
When
see.
they did the biopsy, they tagged it, and then they did the ultrasound after the
I see.
biopsy to check tag placement, and they took ultrasound after ultrasound trying to see the tag, and they couldn't see the tag.
Oh, okay.
So I knew that the area that it had the cancer didn't show on an ultrasound, on a mammogram.
And was the tagged lymph node removed at the time of surgery?
Right, but then a year later, checking to see if I was all clear, it was a big pushback trying to get an ultrasound to see if that cancerous area, which it had like extreme extrusion, trying to get that ultrasound.
I see. Yeah, so
Because
I would
that
say
is
that
controversial.
it's not routine to recommend screening ultrasounds of the armpit to surveil patients, but maybe we could talk afterwards about your case. I'm a little bit confused, so we can talk afterwards.
Okay.
Yeah,
Thank you.
We can certainly talk about individual circumstances, but yeah, and thankfully ultrasounds are pretty safe tests. There's no radiation, so if there's kind of a questionable situation where could it be helpful, then I think it's absolutely reasonable to offer that and include that.
And then we have, I think, our final question over here.
Earlier in your presentation, you talk about treatment plans based on subtypes and stages. How about the breast cancer types like inflammatory breast cancer? How do those map onto sort of what treatment plan you use beyond the subtypes and the stage?
Right. So inflammatory breast cancer, we kind of think of that as a clinical diagnosis, meaning the breast looks red, it looks inflamed. They often use the word peau d'orange, which basically means orange skin. The texture of the skin can change because there's cancer involved. That tends to be a more aggressive cancer, so we tend to use a more aggressive approach for it. So oftentimes we're doing chemotherapy first. We're doing that as a first step. We call that neoadjuvant chemo, followed by surgery, which is most often a mastectomy for an inflammatory cancer. And then after that, we're doing radiation. And if it's estrogen receptor positive, we're also using endocrine therapy. So it's thankfully something that we can approach and attack, but because it does tend to be more aggressive, we tend to use all the modalities that are at our disposal to counteract it. All right. I think we're out of time, but
Can we sneak in one final question? Sorry.
Doctor, thank you so much. Thanks for all the research. You guys work hard. Can you talk about, I was waiting to hear about CDK4/6 inhibitors, Kisqali, because I've been on that with awesome results, Verzenio and Ibrance. Those are like really new stuff. Being a second timer in the breast cancer world, they weren't here 5 years ago. Can you talk a little bit about those drugs and what they do and what they're about?
Sure. So CDK4/6 inhibitors, exactly as you say, they're a relatively new category of medications that we have at our disposal. We use them in estrogen receptor positive breast cancers. And there's 3, exactly as you mentioned, that are on the market currently. And you might have heard ads for them on the radio or on TV. They were first approved in the metastatic setting for people with stage 4 breast cancer. And we found that utilizing those drugs along with endocrine therapy really prolonged the time of response when given as the first line. And then in the last few years, they've done studies in the adjuvant setting. So people who are at high risk for having their breast cancer come back after they've undergone their initial treatment, we can add those medications to endocrine therapy as part of the adjuvant approach. So depending on the drug that you're placed on, it may be for 2 years or it may be for 3 years, and that usually overlaps with the time that you're taking either anastrozole or tamoxifen. But we find that it significantly decreases the chance of a breast cancer coming back. And so absolutely, it's a very valuable tool that we now have at our disposal. All right. Dr. Liu and I will be here, so if there's any questions afterwards, we're happy to take those and chat.